Welcome, everyone. Thank you so much for joining us for today's Open Mind program. I'm Vicki Goodman, and it is my honor to introduce today's special guests, Dr. Sara Manning Peskin, Assistant Professor of Clinical Neurology at the University of Pennsylvania, and author of the new critically acclaimed book, A Molecule Away from Madness, Tales from the Hijacked Brain. We are also honored to have with us Dr. Jennifer Kruse, Health Sciences Associate Clinical Professor of Psychiatry at UCLA, founding director of the UCLA Consultation Liaison Psychiatry Fellowship Program, and I'm proud to say the recipient of the Huvane Family Friends of Semel Research Scholar Award. We are very grateful to both Dr. Manning Peskin and Dr. Kruse for taking the time from their busy schedules to talk to us about the brain, the mysteries of the complex human brain, and about the unruly molecules and the mind-altering diseases like Alzheimer's, Huntington's disease, and temporal frontal dementia that can form in their wake. But Dr. Manning Peskin says there is hope. So we're really looking forward to hearing about that from her. For those of you who are with us for the first time, the Open Mind Lecture and Film Series brings together thought leaders at the intersection of science and culture for meaningful and relevant programs about mental health. It's proudly sponsored by UCLA's Friends of the Semel Institute for Neuroscience and Human Behavior and the Resnick Neuropsychiatric Hospital Board of Advisors. Just a few housekeeping notes before we get started. Today's program will run for approximately 1 hour, with the last segment reserved for your questions. If you would like to ask either of our speakers a question, we ask that you please type it into the Q&A that is located at the bottom of your Zoom screen. We had over 1,200 people register for today's program, so please be patient. We'll do our best to get to as many questions as possible in the time allotted. Today's program is being recorded and will be available for viewing tomorrow on our YouTube channel, which you can find on our website, friendsofsemelinstitute.org. There you will also find a library of videos from past Open Mind programs and videos from WOW, the Mental Health Summit that was jointly sponsored by the Friends and the Resnick Board with Oprah, John Batiste, and the Surgeon General, Dr. Vivek Murthy. Please be sure to look at our calendar of upcoming Open Mind events and special events, including the Open Mind Film Festival for high school students that will be held in person for the first time this year at UCLA and also live streamed on Sunday, April 21st. And we are excited to announce that our inaugural Gen Z Wellness Summit, sponsored by the Teen Advisory Council of the Friends, will be held in person on Sunday, February 25th at UCLA. This event is free for high school and college students, and there will be discussions about the unique mental health challenges that teens face today, along with some great Gen Z spoken word entertainment, some musical entertainment, and comedian. So visit our website for more details, and registration will be available soon for the Gen Z Wellness event. And now, excuse me, now let's all gain some new wisdom by listening to Dr. Sara Manning Peskin in conversation with Dr. Jennifer Kruse. Please join me in giving them a warm Zoom welcome. Thank you so much.
Thank you so much, Vicki. I'm so glad to be here. And Sara, so great to have you here with us. Could we start off by having you tell us a little bit more about why you wrote the book and what are some of the key messages that you wanted people to take home from it?
Yeah, so I wrote the book because I wanted to capture the way that cognitive neurology is basically on the precipice of a revolution, and the way that we treat brain diseases is changing. And we're basically following in the footsteps of oncology. So part of the reason why people have gotten so good at treating cancer over the last 20 to 30 years is because they've developed this model where a patient comes in and you take a piece of their cancer out and you look at it under a microscope and you figure out which molecules are abnormal in that cancer. And then you look at your shelf of treatments and you pick out a treatment that's tailored to that molecule. And the idea of the book is that that's also where we're going in terms of treating diseases of the brain. So the book's divided up into 4 different sections based on these different types of molecules. And the first section is about, I called it mutants, which these are diseases that are caused by single DNA mutations. And so if we think about DNA as sort of the instruction book for how to run a human cell, these are diseases where that instruction book has a typo. And so one of the chapters is actually about Alzheimer's disease and about this unusual population in rural Colombia, where they have a particular genetic mutation that causes Alzheimer's disease, and it causes it actually in their 30s and 40s and early 50s. So it's a very, very young onset. And the story is about this Colombian neurologist who discovered this population and has worked with them over the past several decades, and actually got things to the point where they're doing clinical trials to see if we can treat Alzheimer's disease in this population. The idea being that, maybe the cure for this disease is not in your sort of typical 80 to 90-year-old with Alzheimer's disease, but actually these people on the molecular fringe where it's caused by a particular mutation. The second section I called mutants, and these are stories of diseases that are caused by proteins. So if we think of DNA as sort of the instruction book, proteins are like the workhorses. They do most of the work of keeping cells alive. And for the most part, they're helpful, but sometimes they turn on us. And so one of the stories in that section is about a young woman who she kind of overcame adversity, went off to college, finished college, came home, and then the summer right after college, she started getting very quickly very confused. And she started thinking that she was actually living in The Walking Dead in the TV show. And it turned out that she actually had a disease where her immune system was attacking her brain. It was a disease that was only discovered in sort of the mid-2000s or so. But she actually was treated, and she is back to living her normal life because of the work of the scientists who discovered it. The third section is about invaders, is what I called it. These are diseases that are caused by small molecules. And so if you think of DNA and proteins are these really giant molecules, but there's also lots and lots of little small molecules, namely, medications is a big one. So most people take, the vast majority of people take some sort of medication from time to time or regularly. And most of those are small molecules. And one of the stories in that section is about Abraham Lincoln. And there was this idea that he actually might have had mercury poisoning because of a medication that he took that was very high in mercury content. And then the last section is about evaders. So these are small molecules that cause a problem, not when they're present and they shouldn't be, but actually when they are not, when they're absent. So when we need them and they're not there. And the big model for that is vitamins. And so one of the stories in that section is about a disease called pellagra that essentially tore through the southeastern US in the early 1900s, was extraordinarily deadly, killed thousands and thousands of people, until the scientists, who was incredibly persistent, figured out that it was caused by a nutritional deficiency. And so the goal of the book really is to create this sense both of, isn't it amazing how many ways the human brain can malfunction with these tiny molecular changes? But also, look at this. We all look around and most of us are actually doing fine. Most of us don't have any of these diseases. And how incredible is it that the brain is so resilient? And that this is sort of, despite all of this, we actually are these extraordinarily successful creatures from a cognitive perspective.
Great. Thank you. We chatted about this before, but I really enjoyed listening to the book. This that's my preferred reading technique is to listen on a flight back from a work conference. And after I returned, I've been, looking up different studies and things. It's just so fascinating, so much of what you write about. I think one thing that is, of course, of such interest to, clinicians, scientists, and especially patients is dementia and the increasing prevalence of Alzheimer's dementia and the fear around that. What can I do to prevent it? What can I do if I'm in the early stages? What can I do for my mom or my grandmother, right? So it's really fascinating for me to sort of, read about this family in Colombia and hear all of that backstory there. Of course, there's been some news, some new treatments coming out recently, but it's a little bit hard not kind of being in your world, knowing how the doctors like you are kind of weighing the data, weighing sort of the reactions of the FDA panel, which were obviously not unanimous. I believe 3 people like resigned from the panel after the FDA approved one of these drugs, if I'm not mistaken. So just really interested in your read of the data and how you counsel your patients around some of the new agents. This is turning into too long of a question, but also kind of what's coming down the pipeline.
Yeah, how do we talk about it? No, it's a fascinating time to be in the field. And as I've been telling patients over the last sort of month or two, give me some feedback, because I'm new at giving this spiel, because the way that we talk about the landscape of Alzheimer's disease treatment is actually changing, and it's changing now. So Alzheimer's disease is defined by buildup of these 2 proteins. One is called amyloid and the other is called tau. And that's what the original Dr. Alzheimer's actually discovered. His story is actually in the book. It's a fascinating story. But that's what defines the disease. And for a very long time, people thought that if you could get rid of amyloid, you could stop or slow the disease. And the reason they selected amyloid rather than tau is that there's a few reasons, and for one, amyloid tends to build up about 10 to 15 years before tau builds up in the brain. Tau tends to build up more along the lines with symptoms, but amyloid tends to build up actually, a decade before any symptoms develop. It's already all over the brain. And then there are some mutations that cause Alzheimer's disease, and most of them affect amyloid. And so for that and a few other reasons, people basically said, they developed this amyloid hypothesis and this idea that if we could get rid of amyloid, that's the key to solving this disease. And for many, many years, we spent billions of dollars developing drugs that get rid of amyloid, and nothing worked. And there was 2 ways that people reacted. One is that people said, we're barking up the wrong tree. We should totally change our approach. And then there was another group of people who said, maybe the problem is not the approach, but actually the strength of the drugs. And maybe the problem is just that our drugs aren't strong enough. They're not good enough at getting rid of amyloid. And so the research kept plodding along. And then the first sort of big thing that was splashed on the news was that drug that you sort of referenced was a drug called aducanumab. And that drug was tested on a very large population. There was 2 phase 3 trials that were enormous. And the company that was running the trials actually stopped the trials in the middle because they thought there was no effect. And then the company actually went to the FDA, requested approval. The FDA, in a little bit of a surprise for everyone, gave it approval. And that was when you talked about where the FDA advisory panel, 3 of the people actually resigned. There was a total uproar. And we were sort of left saying, this drug may work or it may not work, but we don't have enough information to know. And so we can't recommend it to patients. And then fast forward to this year, and we actually got a little bit of good news. So there was another drug called lecanemab that also cleans up amyloid. And it's also one of these sort of super strong drugs. And the data for that came out, and that was actually, relatively clean data. And essentially the takeaway is that it slowed the progression of Alzheimer's disease by about 25% over an 18-month period. Another way to think about it is it's about 4 to 6 months less progression over an 18-month period. And so it didn't stop the disease in its tracks. It's not like immediately when you get the drug, you freeze there and your cognition is preserved. The people who got the drug still progressed. But it was groundbreaking in the sense that this is the first time we've ever seen an effect size that big with statistical significance. So from a scientific perspective, this is huge. From a clinical perspective, it's a little more complicated. And the reason being, are several. So one is it's a complicated drug to take. So it's an infusion every 2 weeks. You need frequent MRIs because you need monitoring to avoid side effects. It's right now, Medicare has said they're covering it, but most private insurers or a lot of private insurers are not covering it. So it's actually not accessible to a lot of people. And it has these side effects. So the side effects, the 2 big ones, one is inflammation of the brain, which sounds terribly scary, but actually didn't cause people that much long-term effects. But the other big side effect was bleeding in the brain, and it can be catastrophic. That's a big deal. And so we're still learning about, what makes someone at a higher risk of having one of those side effects. How do we use these drugs? Who do we give them to? And that's going to be a little bit of a learning curve for all of us. The way that patients have been reacting so far is there's kind of two different reactions that we see. Some people are saying, my intellect is so critical to my identity. It's such an important part of who I am that I wouldn't care if I had to go to the hospital to get an infusion once every 2 weeks if it meant that I could still do the things that I want to do in life. And then we have other people who are saying, if I have to go to the hospital, once every 2 weeks to get an infusion, and I have to do that over 18 months, and that only buys me another 4 to 6 months, but I've had to spend that entire time going to the hospital all the time, and I have a risk of bleeding, that's not worth it to me. And the other piece of it is, a 25% slowing that's not 100% slowing. The study basically showed over the course of the 18 months, the difference between the people who got the drug versus who didn't get the drug seemed to get bigger over time. So the hope is that, maybe if you're on the drug for 3 years or 3 years after you get the drug, suddenly, the difference between getting the drug and not getting the drug is bigger than 25%. And maybe that's more worth it. But we don't know because we don't have that information yet. So it's really, it's a very new field. And the other thing that's coming down the pike is donanemab, which is a new drug that they're going to make a decision about approval by the end of the year. Our suspicion is that it probably will get approval. And that drug is actually an infusion only once a month. And the way that study was done, they actually scanned people to look for amyloid. And if people had a repeat scan that didn't show any amyloid anymore, they stopped the drug. And so suddenly that's actually a much different proposal. Now now we might be able to say to people, look, you could get an infusion once a month. There's a 60% chance that after a year, you can stop the infusions, and it might slow your disease by 30%. And that's sort of a little bit of a different proposal from a practical perspective. So it's sort of, this is very much a moving target, but it's an exciting time to be in the field.
Very interesting. And then presumably they're pursuing tau therapies and other approaches as well.
Yeah, so those are also in the works, but there isn't something there isn't something that's an alternative approach where we're saying, look, that's going to come out in the next few months, and we're pretty sure that's going to get approved and that's going to work. This is kind of the thing that's the closest to the launching board.
Yeah, I found the couple of cases in the Colombian family really fascinating, where they didn't develop early dementia in the way that they were predicted to based on having the mutation, and then were found to have a different mutation that perhaps is in some way protective. So to your point of kind of, I guess, the complexity and yet maybe the simplicity of like starting with these people who have like a very specific molecular finding to then, investigate in larger samples.
Yeah, those cases were fascinating. And it's exactly right. Those people who they were carriers of this mutation. So you would guess that they have basically 100% chance of developing early onset Alzheimer's disease. And yet they got into their, 60s and 70s with essentially normal cognition. And then it turned out they had these secondary mutations that actually prevented them from developing Alzheimer's disease. And the significance is that we look at those secondary mutations and say, look, can those actually give us information about potential new targets for therapies?
Something else I wanted to ask you about, it was more about like the writing of this and the process for you. It is reminiscent in a way of Oliver Sacks, and many people on the webinar may or may not know who that is. But if you could talk a little bit about kind of some of your inspiration and your approach to the book, as well as what it was like to kind of find these families and really get such a deeper, more intimate look at their lives and their families.
And so Oliver Sacks basically, he kind of defined the field of narrative neurology. So he basically created the idea that people who were not sort of trained in medicine might be interested in the stories of people who had brain diseases. And he kind of established that as a concept, so that the idea of picking a book off the shelf that's written about people who have brain diseases is not a totally foreign concept for the average person who's not in medicine. And a big part of what I wanted to do in the book is sort of create an understanding for readers of what it's like to live with these diseases, and who are the people, not only their experience with disease, but who are they just as people outside of that? What do they like to do in their spare time? Do they have a good sense of humor? Are they, the patriarch of their family? Are they, the mischief maker? So what are their personalities? And I ended up deciding, I wanted to interview patients. I didn't want to do composites, mostly because I sort of felt like if I did composites, I worried that I was going to sort of put too much of my own opinions into it. This is what this disease is supposed to look like. And so I'm just going to create this synthesis of a bunch of people who I think I've seen over the years. I really wanted to tell specific stories. So I changed people's names, but other than that, I really tried not to change details. And only 2 of the patients were patients who I actually had cared for, and they weren't under my care when I interviewed them to sort of talk about the experience. And when I first started, I think I was worried that it was imposing to go to someone's house and ask them to tell me about their disease. A lot of these are intimate details, especially because these are cognitive diseases. So these are diseases that actually get to the heart of people's identities. And oftentimes these diseases make people do things that can be embarrassing, that can carry a lot of weight. And so it's hard to get someone to go and talk to you about these things, especially for the purpose of writing about it for the lay public. But actually, over time, I kind of realized that there's something very fulfilling about it for patients, I think. When people have chronic diseases, or even when they have, diseases that are sort of fulminant and then resolve, it's very rare to sit down and tell the entire course of your illness story. So oftentimes it's like you have a symptom, you show up in the emergency room, you say, look, I was fine 5 days ago, and then now I'm having, whatever. And then you get admitted to the hospital, and then, something comes up, you tell the same story. And then they come to see you over the course of the day, and you say, like, okay, like over the past 24 hours, this is what's happened to me. And then you get discharged and you go home. And then nobody asks you how things are going until you show up at an outpatient office. And then they only want to hear about, the past few weeks or the past few months. But it's very rare for people to sit down and say, look, this is where this started. This is what my life was like before all of this. And this is how I've been through this whole course. And this is where I am now. And actually sitting down and doing that, I think was actually fulfilling for people. It's sort of neat to hear how people articulate an entire arc of an illness.
Yeah, very much so. And it's interesting kind of the correlates to like talk therapy, really, in terms of, it's a traumatic experience for anyone to be going through any serious chronic illness, and to be a family member, and kind of the processing. I can imagine being quite therapeutic to have a caring person kind of listening. And there's even a type of therapy that some may be familiar with, called dignity therapy. Sort of at the end of life, you kind of, do an open reflection, kind of ask lots of questions, open-ended questions about kind of the life course, the experience of the illness. And then, kind of that in itself is put into writing for the patient and their family.
Oh, I never heard of that. That's a great idea.
Yeah. So in a way, it's kind of similar. You've got a chapter of dignity. Very cool. And personally, what was that like for you to kind of, to be in there with the families on such a level like that?
I think it was really neat. I have to say, I tend to be and this is also in my line of work, a lot of what I do is working with families who have genetic mutations that cause dementia. And it's an extraordinarily intimate thing to talk with people about fear of a disease taking over, when they, people who know they're carrying genetic mutations for certain things, they know that they may, not be themselves in 5 years and 10 years. And talking with them. And also some of it was, most of the interviews actually were with people and their family member. So figuring out, what is this? What are the social implications of these diseases? How do family members deal with it? And that was some of the most interesting things, because when people come and I see them in clinic, a lot of it is focused on the actual person. It was neat to actually get to hear more about, their environment and their family members and how all these people are dealing with it.
Yeah, definitely. Very interesting. In terms of the evaders, I think good for us to chat a little bit about that. So that was the section you talked about where you're seeing kind of these very severe forms of vitamin deficiencies kind of as they were discovered. And I think there's a lot interesting in there, both in terms of like bias in healthcare, right? With the pellagra story and everything. But also in terms of our, desire to want to try to do what we can to take care of ourselves. I have a lot of patients who ask, what should they be taking in terms of vitamins and supplements for brain health, cognitive health, and I would welcome your input on that kind of question.
Yeah, that's probably one of the top questions that we get asked also. And there's good reason for it because, we're all worried about our cognition. And oftentimes this sort of, we get particularly worried. We're sort of up in the middle of the night thinking, is this going to happen to me? And our instinct is, why don't I just run over to CVS and get something and that'll make me feel better? That's always what we want to do. Yeah, but it turns out there's really not enough data to tell people to do that, to buy anything from the drugstore that really works in terms of over-the-counter things. The exception being if you are deficient in a vitamin. So if you have B12 deficiency, there is benefit to treating it. But if you have a normal level of B12, there's really no good data that we should flood you with B12. It essentially just comes out in the urine. So you're sort of just throwing away money. And the same is true with things like, Prevagen, a great advertising company, not a great actual product. And it's frustrating because it would be nice if there was something where we could say, sure, just go pick this up at the store and your cognition will be better, but there isn't something like that. On the other hand, there is actually really good data for lifestyle changes that affect cognition. The biggest one is probably exercise. So there is incredible data for exercise. Most of the studies that have been done essentially show benefit with 30 to 40 minutes a day, 3 to 4 days a week of aerobic exercise. Anaerobic exercise for weightlifting maybe has a little bit of a benefit, but it's not sort of as useful. So it really should be something aerobic, 30 to 40 minutes a day, 3 to 4 days a week. And the effect size is impressive. There was a study a few years ago in frontotemporal dementia, and it was a group of people who have mutations where they're essentially going to get the disease at some point if they live long enough for most of these. And it turns out that the people who were the top exercisers declined about 50% slower than the people who were the sort of the non-exercisers. So it's just an enormous effect size. The other big quality of life, or the other big sort of lifestyle interventions, diet wise, the Mediterranean diet has the best data, but it's hard to study diet because people don't remember what they ate. And if you tell them to eat certain things, they don't listen. So I tend to say it's hard to change people. And so if I would choose one, I would choose exercise over diet. But the other is, social engagement. So there was a study back, I think this was in the 80s, where they basically looked at a group of people and you got points for how social you were. So you got a point for like talking to relatives on the phone or being part of a religious community, having a partner. And the more points people had, the less cognitive decline they experienced. And the last is intellectual engagement, which is, the idea is people should be sort of kept on their toes in some ways. So sitting and watch TV all day is not great for the mind. The same as, it's not great for kids. It's also not great for older adults. And the other pieces are things that a lot of people do already, which is, don't smoke and don't drink too much. But those are really the main things that we have control over. And then there's a lot that we just don't have control over. And a lot of sort of talking to patients in my field is sort of figuring out how do we cope with the fact that we don't have total control over a process that is changing.
Right. So much of medicine, right? You and I had talked a bit about this a week ago, but a few years ago, there was an article that came out that made a big splash about which medications that you may be taking that may increase your risk of developing cognitive dysfunction, decline down the line. I think, I've seen in my practice a lot of anxiety around that article, even if the medicines that they're taking aren't kind of listed or weren't included. Some of the headlines were like, common medicines, associated with dementia, that kind of thing. How do you kind of think about medicines and risks and benefits in relation to an article like that, for example?
I mean, my general approach is I think for the article that you're thinking of is unless there's proof that a medication is actually causing harm, then if it's really needed, it's needed. That we all sort of weigh risks and benefits of things all the time. We get in the car, we cross the street. And so thinking about, the article brought up a bunch of antidepressants that may, have an association with an increased risk of dementia. And so one thing we say is, look, there's also data that having untreated dementia is a risk factor. I'm sorry, untreated depression is a risk factor for dementia. And in terms of quality of life, most people would much rather not be depressed, even if it meant, there was this association with having a higher risk of dementia in the future. Because are you going to go your entire middle life being terribly depressed? So the way that we generally approach decision making for that is, like, if we need these drugs, then we need these drugs, and we use them. And if we can avoid them, then that's great. If it's easy to avoid, that's fantastic. But if you need them, you need them. And a lot of these studies that have been in the press are really about associations and not causations. And that's been part of the issue. So we don't really have proof that these actually cause dementia.
Yeah. And I would kind of add on to that, you already mentioned about depression in and of itself being a risk factor, right? And so we know that to be true, and we know that the effects of depression, especially untreated symptomatic depression, involve smaller volume and, certain parts of the brain, and that effective antidepressant treatment, kind of the downstream way that it seems that all antidepressant medicines ultimately work is by increasing the communication between neurons and synaptic plasticity, right? And kind of, regrowth in some of these structures. So, to stop a medicine that is adequately treating your depression because of anxiety or fear around the effects of the medicine would likely be counterproductive, right? And I should also, as an aside, say that most of the common antidepressants on that list were not actually commonly used. They're kind of some of the older ones, like the tricyclic antidepressants and things like that, which we still do use to really good effect in some instances, but just to give that caveat as well.
Yeah, that makes sense. Those papers probably do a lot of damage in your field, where you have patients who are well treated and now want to come off medications that are working.
Yeah. Not a good thing, right? What else? I had so many lists of questions here for you. Let me find my next one. I'm really interested in autoimmune encephalopathies as well, and have done some research in that area, more kind of describing clinical cases, in particular patients who were admitted to psychiatry prior to ultimately being diagnosed with an autoimmune encephalopathy. And interested in your take on when this is a complicated question. So let me see if I can kind of think and reframe it a little bit. So I work a lot on med-surg units. So people who are medically, surgically, neurologically hospitalized, right? And oftentimes we'll have these really unusual presentations of psychiatric, right? Where, there's just something not quite right. Either it's like this rapid onset, or an unusual symptom profile doesn't quite fit in with sort of, over time you get this pattern that makes sense. And then, this one doesn't fit in, or there's a family history of autoimmunity, or, all kinds of things like that. But, as you mentioned, NMDA receptor encephalitis wasn't even discovered until, the mid 2000s. And surely there are, cases that are driven by autoimmunity that we can't yet identify a specific antibody. Just find this a very interesting area that is, of course, moving at its own frontier. But since it's in your book, I thought I'd ask you your thoughts on it.
Yeah, it's a wild field, and actually, we had an interesting case even recently. So, these are a set of diseases that are essentially caused by an immune system that's sort of gone rogue. So normally we all make antibodies, and the goal of the antibodies is actually to protect us from infections. But it turns out that we make lots and lots of antibodies, and we have to have this system that gets rid of the antibodies that attack ourselves. And that's how it works. So we make antibodies indiscriminately, and then we have a separate way of getting rid of the ones that get rid of that attack the self. And it turns out that system of getting rid of those bad or dangerous antibodies sometimes fails, and that's where we get these autoimmune diseases. And there's a set of diseases that are caused by antibodies that actually attack nerve cells or brain cells. And the sort of most famous one is this NMDA receptor encephalitis. That's the one that's in the book Brain on Fire. That's sort of it's a really striking disease, and it tends to most commonly affect young women. So it's often young women who come in with this really rapid onset psychosis. They can get seizures, they can get, blood pressure that flies up and then drops down. And it's treated with immune suppressants. And so before sort of the mid 2000s, if someone comes in with a syndrome like that, they essentially get admitted to an inpatient psychiatric facility, and they never really get adequately treated because the cause is not an underlying psychiatric problem. It's actually a neurologic problem. But then with this discovery of these diseases, it's now being treated. So the patient I talked about in the book is back living her regular life. And since the discovery of NMDA receptor encephalitis, people have discovered autoimmune encephalitis that's caused by all sorts of different antibodies. So you can have an antibody that attacks essentially any part of the nervous system that can cause an encephalopathy or confusion. So we had actually a patient just recently where if you look at his spinal fluid, if you if you bind it to sections of rat brains, it sticks to the brain. We know there's something in there that's actually causing an autoimmune encephalitis or an autoimmune problem, but it's not any of the antibodies that we know about. So there's something there that's not been discovered yet, and that finding is actually happening all the time now.
That case I found interesting because of the timing. The writer of Brain on Fire, Susanna Cahalan, that was really early on in the discovery of this disorder. I was wondering what year it was when this patient was facing this, because the resistance that the family got from the team in terms of evaluating it, I was just disappointed.
Yeah, the patient I wrote about, it was much more recent than Brain on Fire. But that being said, there's so much going on in neurology. It's hard to keep up on everything. And so I think to expect that the average neurologist who's, treating folks in a rural area where they might be the only neurologist around, how are they going to be up to date on every single new disease that's being discovered? I think it's a tall order. And I think the main takeaway is, when you feel like someone has something unusual, you have to pursue it kind of almost to the nth degree. You have to get second opinions if something is happening that doesn't seem to fit, or if your doctors are telling you, giving you an answer that doesn't make sense. It's worth, getting a second opinion or getting a third opinion. At some point there's decreasing return. At some point, there may be no answer, or at some point, even if the answer doesn't make sense to you, it may be correct. But I think at the very least, when things don't make sense, you get a second opinion.
Yeah, absolutely. And very interesting how parents are often in that role of becoming basically experts in a particular disease and process, right? And how her mother really had to advocate for that next level workup. I thought that was an interesting story too, that I think is so often reflected in, lots of other conditions as well, kind of this advocacy that, it takes sometimes.
Yeah. And I think that's true in any disease, that when doctors see patients, when the patients come with family members, I think doctors actually view them differently. You see people more as sort of whole people when they have someone there who's advocating on their behalf. And so I think, even the story I read about, she was a young woman. And so it sort of, she really needed someone by her side. But I think even for adults, having other people around when you're in the hospital, so that the medical team knows that you have a family, you have a normal life, you're not always dressed in a hospital gown. It's useful, and you get better care for it.
Yeah, absolutely. Yeah, of course, in neurology and psychiatry, I think it's particularly important because we're always looking for that collateral source of information, right? Because the patient may not know that they're sick, for example, right? Or not able to provide because they're confused, a clear history of the time course and all those things. So absolutely, I think that's really an important point.
Yeah, I think psychiatry probably it's probably even also because a lot of people don't want to talk about their psychiatric symptoms. There can be stigma around it, and having a family member who says, like, don't you remember the other day when you felt like, you told me that you wish you could die? Oftentimes that will sort of bring something up that they might have not brought up otherwise.
Yeah, for sure. Good. Okay. Think we're about there. We go. I was going to say, I think Vicky's going to be joining us here.
I'm back. First of all, before we have a lot of questions, but before we go to them, I want to thank you both. This was a fascinating discussion, and I think you made us all a little smarter about the brain, and this is such interesting new information. So thank you for sharing with us.
Thanks so much for having us. This is neat.
Well, it's really our honor. So thank you. We have a lot of questions, some that are very specific, some that are general. So I'm going to start with one of the general ones that is asking about psychedelics. And I know there's a lot of new studies, a lot of new information coming out. Can you talk about, is there anything in neurology that is now looking at psychedelics for treatment?
So I have to, in full disclosure, I'm totally not up to date on the literature, so I'm going to have a sorely inadequate answer. The one place I will say this came up in writing the book actually is that story of the patient who thought she was living in The Walking Dead. She had this disease, NMDA receptor encephalitis, and the way that disease works is it essentially it's as if your body's producing its own PCP. And so there's now been this resurgence of using lots of psychedelics. But PCP actually, nobody seems to be using that, even with this resurgence, that drug really is so bad and so toxic and has such terrible side effects that one has not, it's not gone the way of, psilocybin and all these things. But I have to say, I'm not up to date on the literature for the psychedelics. I don't know in psych if you're more up to date on it.
Yeah. I can speak a little bit to it. So yeah, really fascinating work that's emerging and has been emerging over a recent number of years. Basically a resurgence of work that happened in the 50s, 60s, now kind of coming back and becoming more common. A lot of really promising data coming out, though, with some difficulty in terms of interpreting the data. Importantly, because it's pretty hard to have a placebo with anything that you're testing, a trip dose of a psychedelic with, right? Nonetheless, it seems in some of the studies that a session or two with a therapist, it's usually two therapists in a room for psychedelic assisted psychotherapy, where they're kind of helping guide you through the process and then help kind of with the integration of it afterwards. People often report quite intense and healing experiences with symptoms that then can have a pretty long trajectory of improvement. So very, very fascinating work. And at UCLA, there are both in the psychiatry, psychology departments, many who are right at the front lines and engaged in that research. So I think it's, I think there's a lot of promise there. But time will tell how it all evolves.
Thank you both. All right, I'll go to a specific question from one of our listeners. Says, I have normal pressure hydrocephalus with a BP shunt. Now, I'm way out of my field here, so I'm just reading the question. How does your work also refer to NPH?
Yes, it's a great question. So what NPH is, it's a disease where essentially there's too much spinal fluid. So all of our brains are bathed in this fluid, and that fluid goes around the brain and also down the back. And it's essentially cushioning. So if you stop short in your car or you step off a curb, you don't slam your brain into your skull. And we actually make about 500 cc's of spinal fluid a day, but you only have about 150 cc's at a time. And that's because we're making it and we're resorbing it and making it and resorbing it. But there's a condition called normal pressure hydrocephalus where you end up actually having too much spinal fluid or too much fluid. And the thought is that it then presses on the nerves in the brain, and it causes sort of the 3 W's is the way you learn it in medical school. It's wet, wacky, and wobbly. So people have difficulty with urine. They get something called urge incontinence. So they, when you have to go to the bathroom, you can't make it to the bathroom. As soon as you have to go, you actually lose control of urine. They get, wacky is sort of the colloquial term, but they get a form of dementia. They get cognitive symptoms. Oftentimes they have difficulty with multitasking, organization, planning, attention. And they get wobbly. They have difficulty walking, and they have this classic gait. Not everyone has this. Not everyone reads the textbook, but the typical thought is that they have a gait that's what's called wide base. So they tend to have their feet a little bit farther apart. The treatment for it is to do what's called a BP shunt, as the person said. So you put essentially, it's like a straw that goes from the fluid spaces in the brain and then drains into the chest. The research on NPH it's difficult to do. And there's a lot of controversy about the disease, and there's a lot of variability in terms of how aggressively people will have these shunts placed versus not doing it. One big piece of information that's come out over the last decade is that it turns out if you have people with NPH and Alzheimer's disease, they don't tend to do as well when you put a shunt in them. So there are some thoughts that if you have someone who has NPH, you should also make sure that they don't have Alzheimer's disease, because if they do, you might actually not do the intervention. And then there's also some issues with people. Once you have the shunt in, sometimes it needs to be adjusted, and sometimes people continue to progress, and we don't know why. So it's really an area where there's a fair amount of research, but there isn't a thought that it's generally, it doesn't tend to be hereditary. It doesn't tend to be caused by a single molecule. And so it's in some ways a little bit of a harder target than some of these other conditions.
Thank you. Now go to a more general question. A few people asked about meditation and cognitive health. And I'll throw in mindfulness, because I know a lot of people are now practicing mindfulness. Can you comment on that, both from neurology and psychiatry? We have 2 experts here.
And we're probably looking at the same studies, actually. We're probably using the same group of studies. Most of the studies on mindfulness are on the smaller side. So it's not like there's not a phase 3 placebo-controlled study of mindfulness. So the data is not as strong as for, a pill that you take or an infusion. But there is a lot of good data that mindfulness is helpful. I'll say a big area that sort of type of treatment is relevant for cognitive neurology is actually in sleep. Because it turns out poor sleep has a big link to Alzheimer's disease and to dementia in general. And one of the big treatments is something called cognitive behavioral therapy for insomnia, which is essentially teaching people, how do you teach your mind to fall asleep if you can't fall asleep? How do you teach your mind to fall back asleep in the middle of the night when you're having trouble? And that type of mindfulness is really a big part of our practice in terms of maximizing cognitive health.
Yeah. So I think probably, similar studies. So actually, and Mike Irwin, who many of you may know that name from all of the work that he's done. They've done a lot on insomnia, aging, inflammation, including interventions like mindfulness interventions, CBT for insomnia, and do show that that these interventions both reduce inflammation, help with insomnia, and in fact, have a role in preventing depression onset. So a lot of really interesting things there in terms of mindfulness meditation. And frankly, I bring it up with every single one of my patients. We talk about mindfulness, we talk about nutrition and movement, because those are things that, aren't a medication and that we have some agency over. although it's pretty hard to make big changes, especially if you're struggling with a serious condition. But mindfulness, I think there's nice data on helping reduce inflammation, improve sleep, and both of those things should have theoretical feed-forward benefits for cognitive health.
Thank you both. There are quite a few questions here about some medications, about statins, about are there specific antidepressants? I know you talked a little bit about that might cause dementia. And also, I'm going to throw in there, because I know, Jennifer, you're studying Ozempic, I believe, and some of the new medications that people are using for weight loss. Is there any information about those and regarding some of these mind-altering, brain-altering diseases?
So for statins, we were worried about statins for a long time, but the data on statins never really panned out. So actually, if anything, I tend to, if someone has high cholesterol, we want them on a statin, because we know that having high cholesterol increases the risk of damage to the blood vessels in the brain that can cause vascular dementia. So actually, very much, we do not take people off of their statins. And we generally think of those actually as a useful class of medications. In terms of antidepressants, a lot of it has to do with the way that particular antidepressants affect the neurotransmitter called acetylcholine. So it turns out that people with Alzheimer's disease have lower levels of this neurotransmitter called acetylcholine. And there's this connection to medications that are what's called anticholinergic. So medications that are sort of tamper down the acetylcholine system. Those medications can tend to cause more confusion and are associated with a higher risk of going on to have dementia. And some antidepressants are more anticholinergic and some are less anticholinergic. So I can tell you that the antidepressants that we use most often in our population, even folks who have cognitive impairment, who have dementia, we tend to use a fair amount of Zoloft and a fair amount of Lexapro. Those are sort of drugs that have been around for a very long time. Drugs like Paxil tend to be more anticholinergic. I worry about that a little bit more in our population. And then there's a whole slew of newer antidepressants also. But those are kind of the big names that come up frequently. And there's a lot of the older ones in different classes. The older antidepressants in different classes can be more associated with cognitive issues. But generally, a lot of the big names are actually just fine in cognition.
Yeah, I don't think I have anything to add to that on the antidepressant front, other than most of the antidepressants that we use aren't particularly anticholinergic or affecting this transmitter. Of the newer ones, the SSRIs, I say new since like the 90s. Paroxetine is the one, Paxil, that kind of does have a little bit more of that anticholinergic potential. But as per the prior discussion, for some people, that medicine has, changed their life, and, they function well now. So every kind of conversation and decision made in medicine, as Sara has referenced, is, this risk benefit assessment. And then there's also, some of them, they're called atypical antipsychotics that we use to help augment or improve the treatment of depression. Some of those can also have a little bit more of that anticholinergic potential. So that's the other thing that I would mention with that. And then about the new ish anti-obesity medications, I'm interested in your thoughts on these two, Sara, because I'm really excited about the potential. And that's what I will say, is it's the potential, because we don't have all the data we would need to kind of assess this yet. But my work in mood disorders really, focuses on the role of inflammation, which, you get inflammation normally if you need to fight an infection. Your immune system gets ramped up, fights the infection, and then it goes back to normal. But there are conditions in our day-to-day lives now that kind of are chronically creating this low level of increased inflammation. And increased inflammation has a lot of negative effects when it's on a chronic basis. Cardiovascular disease, diabetes, cancer risk, dementia risk, et cetera. One of the primary drivers of inflammation in the body for most people, most otherwise healthy people, is excess adipose tissue, which produces extra inflammatory molecules. So that's kind of a long-winded way to say how I got really interested in these medicines, because usually, we know that higher inflammation is associated with development of depression. It's also associated with poorer response to depression treatments. And so we focus a lot on trying to find, okay, what are some of the predictors of why and how people will respond to some medicines and not others. But these new agents, for the first time, really have a direct way for us to engage and decrease inflammation in people. And so that's what we're looking to do for our patients who have both depression and obesity, both of which are risk factors for multiple different medical conditions, comorbidities, disability, including dementia, right? So I'm really interested to see how adequately treating weight problems, overweight and obesity, impacts, even from an public health standpoint, rates of depression and rates of dementia. Again, I'm not. I've got excitement about it. We don't have that data yet, but I think it's a really fascinating area, and Vicki and Wendy are very familiar with this, because this is part of what we're studying in our patient population, is the effect of treating obesity adequately on both depression, as well as how the cells are functioning. How do your the way that your cells are using energy, how does that relate to how you're feeling, right? And how do these meds shift that? So I think a really exciting area with a lot left to learn. And I will also note that with any sort of rapid weight loss, for example, bariatric surgery is a highly effective treatment for people with obesity who need to lose a lot of weight and who would benefit metabolically and health-wise from losing a lot of weight. In the early phases post-surgery, there's an increase in suicidal thinking, which is interesting. It's not clear why. But there's an overall market improvement in depression in patients over the long term, for people who do have substantial weight loss with bariatric surgery. So there have been, again, these recent headlines, reports, patients reporting suicidal thinking with new weight loss drugs. So this is all, to be determined, and we'll kind of see how it evolves over time. But that's that sort of caveat that I wanted to sort of make sure I mentioned, so I'm not giving a total one-sided perspective.
That's such a neat field. It also seems like, because studying those drugs in dementia is a tall order, partly because people are going to be going on and off the drugs. And because dementia takes so long to develop that, they're only really being used it's only, they've gotten widespread use like this year and last year. So people who are using them now, it may be many years before you actually figure out whether they develop dementia, how you detect it. So that's going to be a long ways off, that research. But with psychiatric symptoms that are more, they can fluctuate, you can measure them in real time. That's an incredible context to study. And I never thought about that. That's a great idea. Yeah,
we do in our, in the published literature, but also in our preliminary data, there is a relationship when you kind of take into account all of the other factors like age and sex and education and everything. For depressed patients or patients who have bipolar disorder, BMI does correlate with performance on cognitive testing, just cross-sectionally. So kind of another just kind of interesting data point that, who knows how that relates to long-term, as you're saying, but could at least measure in a relatively short-term changes in, cognitive functioning for people who don't have dementia. We don't know who's going to then go on to develop it or not, right? So major limitation there, but interesting nonetheless.
That's so cool.
Thank you both. Unfortunately, we're out of time. This has been such a fascinating discussion, and I'm sorry we can't get to all the questions. But Sara, I want to thank you for the gift of this book. The fact that you wrote it as a storyteller, I know it's very a la Oliver Sacks, but it's really refreshing. And I know that you talk about some of the doctors that made these discoveries that really never got the recognition. So thank you for doing that. And thank you for the work that you both do to help people with these illnesses of the mind and brain. And one of our viewers said also, thank you for writing it from an optimistic view that, as you said, most of us are okay. And that's very refreshing and very good to hear, especially from an expert. So thank you both really, and thank you everybody for tuning in, for the privilege of your time. We're really grateful and very honored to have you here. And we'll look forward to seeing you for our future Open Mind. In fact, we have one a week from tonight, October 19th, 5 p.m. We're going to be showing a very short film called Normal Sucks. It's based on a book by Jonathan Mooney, and it is about neurodiversity. And our faculty speaker will be Dr. Ned Hallowell, who is a world-renowned author and expert on ADHD. And the filmmaker, Peskin Rivas, will be with us as well. So I hope you'll all join us for that discussion. And everybody stay safe, stay well. These are really difficult times for many people. So very grateful for you sharing your time with us. Good night.